Hello, welcome to JAMA Network Open Live. I'm Seth Kruger, Digital Media Editor at JAMA Network Open.
And I'm Angel Desai, JAMA Fishbein Fellow.
Of course, if you're following along live, send us your questions or comments. You can mention us on Twitter at JAMA Network Open or comment in the comment box under the video on Facebook or YouTube. Today, our author is the first author from the assessment of proficiency of N95 mask donning among the general public in Singapore. And we've got first author, Dr. Wesley Yong, with us. Welcome, Dr. Yong.
Thank you.
Thanks. Really glad you could join us. Tell us a little bit about yourself and why you did the study.
So our group is at the National University of Singapore. So the background to this study was that in 2013, Singapore and many countries in Southeast Asia were affected by a particularly severe episode of haze. And haze is a term that is used to refer to episodes of severe air pollution caused by biomass smoke. So the Singapore government at that time responded by distributing N95 respirators to every household in Singapore, accompanied with an instructional leaflet on how to wear them. So we suspected at that time that without formal training, most people would not know how to wear them. And the idea is that if you wear the mask incorrectly, you just don't get as much protection. So the fieldwork was done in 2015. We went out to the community and did a cross-sectional study and just to figure out how many people could actually wear the same model of N95 mask that was distributed. And what we found that was only 12% were able to pass a visual mask fit test. And perhaps unsurprisingly, those who had received prior mask fit training actually were more likely to pass the test. But reading the instructional leaflet itself did not actually improve pass rates. So I think what we found was that N95 respirators are not as simple to wear as you might think, and just simply distributing them to the public without proper training programs is likely to be ineffective.
Yeah, and I think one of the things that was really interesting to me is, especially at the beginning of the COVID-19 pandemic, there were a lot of calls from community members and things like that. A lot of I think debate about whether or not non-healthcare workers should be wearing masks in the community. And I remember basically turning down offers from friends who wanted to make masks because it was like, you know what, if you can't make N95 masks, does it really matter? So I guess this kind of gets into whether N95, is civilian use of N95 mask a waste of resources?
So, I mean, with the current COVID-19 pandemic that we're facing, so N95 masks are a really limited resource. And if we just distribute them to the public and do not prioritize the frontline healthcare workers and first responders who really need these masks, I think the fact that most people cannot wear it properly just further strengthens the point that we should maybe prioritize them to those who need it the most. And perhaps in other kind of public health situations where mass distribution of these masks are part of the public health strategy, it has to be coupled with a proper training strategy beyond just like sending printed instructions.
Yeah, and I think that makes a lot of sense. Before I get into that, we've got Adib Kawaji and Ann Kruger who joined us. Welcome. We're talking about N95 fit tests among non-healthcare workers in Singapore. And, I've seen, and I think, my experience, I've been fit tested since, I think, the early or the mid O's, the beginning of the millennium, this century. And this year, when I shaved my beard and got fit tested at the beginning of the COVID pandemic, I was certainly paying a lot more attention during fit testing and I would say at least refreshed on some things. And I see healthcare workers make mistakes all the time. And I'm sure that I'm making mistakes. It's not that simple to put on these masks.
Yes. And some of the mistakes that we found in this study was that they were pretty obvious. So people were wearing the mask upside down. They're leaving a large gap between the mask and the skin. The straps were placed all incorrectly. And this was despite there being pretty clear printed instructions as well. So, the training definitely needs to be considered as part of any kind of public health strategy.
Right. I remember one of the things that shocked me the most or surprised me the most was learning, you're supposed to squeeze the end or push down the sides of the mask, not squeeze. And there's just, I think, big instinct to try to squeeze them.
Yeah. Can you, just to take a step back, can you actually just explain a little bit about what a visual mask fit test is? Because I think that was the way that it was sort of determined whether or not a person was wearing it correctly, right? And I ask this because, I think like probably Seth and I are familiar with in the healthcare worker setting, they spray the stuff and you're supposed to, when you're doing the fit test, to see if you can smell it. So it's like a little bit different. So just wondering if you could explain that a little bit.
Yeah, so what you just described is called a qualitative mask fit test. Mm-hmm. So where they'll put a hood over your head after you wear a mask, and they'll spray a chemical substance, typically saccharin. So it's not really feasible to do this in the community because we have to carry all that equipment out. So a visual mask fit test is a somewhat simplified version of this, where we assess the actual steps, and there are 5 points that we actually assess. So firstly, to properly don a mask, the respirator must be oriented on the face and held in position with both straps. The straps have to be correctly placed with the upper strap high on the head and lower strap below the ears. And for those with long hair, the lower strap should be placed under and not over the hair. The nose clip must be tightened to avoid gaps between the respirator and the skin, and any facial hair should be removed before donning. So in general, these are the steps that are part of the visual mask fit test.
Yeah. I'm going to welcome Luis Garcia and Beo Beatak, who've joined us. Welcome. Apologies for my pronunciation as usual. And I think that's interesting. So, because I think ultimately the visual fit ends up being a relatively lower bar than the qualitative, because you're not actually assessing whether chemicals are going in or out of the mask. And yet the pass rates were still so bad.
Yeah,
exactly. Yeah. If we did a qualitative test, I think the pass rates will be even lower. That's our suspicion.
Yeah. One other thing, you were talking about how people who had previously had some sort of mask fit training had that was sort of associated with a higher pass rate, and I think younger age was as well, if I recall correctly. Why? Do you have any ideas as to why that might be?
We don't exactly know. We can suspect that it could be that they maybe have more access to media or the internet, where they can kind of read up on the instructions, because N95 masks were a thing back then, as a kind of personal measure that you can take to protect yourself against the haze in Singapore. So that could be one of the reasons.
Interesting.
Yeah, it's also interesting. I think if we bring up the visual abstract, you can see some of the major factors, and you see the prior mask fit training had a prevalence ratio of 3. Previously owning a mask was 2.2, but the confidence interval gets down to 1.2. But reading instructions and using a mask previously, they have, say a positive signal, but the confidence interval goes, a bit below 1. Not super close, it's 0.93 and 0.74, but definitely low or below 1. And I think, it's the kind of thing where I don't know. I want to be a little optimistic and a little Bayesian here, that maybe if there are factors where, the reading instructions isn't a panacea, but it's probably helpful. Does that resonate with your experience with this, or did it just seem useless with the instructions alone?
No, it's definitely, you definitely need to have instructions, because if not, there is almost no basis for actually wearing the mask. If you just look at the mask itself, it's not like a surgical mask where it's pretty straightforward where you should put the strap. So I think the instructions are part of the solution, but maybe I think there was another study that we cited that actually looked at evaluated video training versus in-person training versus just printed instructions, and video training and in-person training were superior as expected. So some form of a more interactive or visual kind of training might be necessary.
Great. And we've got a question from Beo Beatak on Periscope, and you don't need to know the answer, so it's fine. But do you know what is the difference between a KN95 versus an N95?
I don't actually know. I don't have that information.
Okay, that's fine. I don't know either. I feel like I looked it up a while ago when this all started, and there were different options for masks. And I think the KN95 does everything an N95 does, but also I want to say is resistant to solvents. but I might be wrong on that. So we'll look it up and get to it next week, and then forget and do it the following week, or we'll follow up in a tweet afterwards. All right, great. Yeah, I mean, I think this is really interesting. I mean, I guess also one of the other frustrations I found is a lot of the N95s that I see people wearing are kind of the kind that people have around oftentimes for household products or donated from construction sites that have the basically an open outflow vent. There's probably technical terms that better describe this. But basically the ones like they've got the little box and then it's basically just a one-way valve. But my understanding is most of the reason we want the broad population wearing a mask isn't to protect the mask wearer, but to protect everyone around the mask wearer in case the mask wearer is an asymptomatic or pre-symptomatic carrier. Can you speak to that at all?
So I think the existing literature really supports N95 mask use where there is risk of aerosolization. And that's typically not a situation that most members of the public find themselves in. So I think it's still an open question as to whether what level of protection is really going to be the answer. But we have to take that the earlier resource constraints into consideration as well. I think those are very important and practical factors we have to consider. Yeah.
Yep, absolutely. Well, great. I think that brings us to the end of our time. Thank you so much for joining us. This is really interesting work and very important stuff. That especially as we're starting to, get really broad swaths of the population across the world wearing masks to try to stop or control the pandemic. This is all very important work. So thank you very much, and thanks for joining us.
Thanks for having me.
Absolutely. Great. So we are going to move on to our next paper, which, if I can figure out my computer, is the prevalence and clinical presentation of healthcare workers with symptoms of coronavirus disease 2019 in 2 Dutch hospitals during an early phase of the pandemic by Kleutmans, Vandenberg, and colleagues. So this is an interesting study. So they basically did the first 2. They had data from the first 2 weeks of the pandemic in 2 hospitals in the southern Netherlands. One was 700 beds, one was 800 beds. So pretty big hospitals. And basically from March 7th to March 12th, they asked people from the last 10 days if they had any sort of symptoms. They did PCR on everybody who had any sort of positive symptoms. And then they did interviews on people with positive PCR tests from March 12th to March 16th. And then importantly, if we look at the figure here, the first Dutch patient was reported with COVID-19 on February 27th. So they were basically looking after the first 10 days after there was a first positive test of a patient in the Netherlands. But as we see, a few people reported symptoms from before that patient was actually officially positive, which is frustrating because, we can't tell exactly these people who had symptoms for, 10 full days and tested positive if it was the same illness, but probably was. So what they found is there were about just under 10,000 workers in the hospital, healthcare workers. There were 1,353, so about 14% who had either fever or respiratory symptoms, things like cough or shortness of breath, which was really the initial case definition of COVID-19. Of those, only 86% tested positive, which is just over 6%. So it's not none. And this is also early on the pandemic, so there was presumably not a lot of either nosocomial nor community spread. Some of the concerning things, however, were that most of the healthcare workers had very mild symptoms or no symptoms, or had very mild symptoms. I can't say no symptoms. Only 53, just over half, had fever at all. And then perhaps most disheartening, and part of the reason why we're here looking back at this pandemic that's still in progress, is that only 3 of them had specific travel to Wuhan or northern Italy, and only 3 of them had definitive exposures to positive patients where we could really pin down. So either they were getting unknown nosocomial or unknown community spread. And like I mentioned, 7 of the patients had symptoms before the first official Dutch positive patient. Some other things they found out was that these patients were spread across 50 different departments in the 2 hospitals. A quarter of them had no discrete patient contact or patient contact roles. So this definitely wasn't specifically you took care of a patient who had COVID-19 and then got infected. And in order to get to ask enough about symptoms to get people to screen positive just by symptoms alone and catch all 86 of those, you would need to add both myalgia and general malaise to the list of symptoms. So like at my hospital, like a lot of places, we're doing temperature checks. It's one of this like live video that tests your temperature as you're walking up. They ask you if you have symptoms and if you've been around anybody who's positive. I don't think any of us expect that to be completely sensitive, but it may not be. We would certainly need to increase, or I think we all agree we need pretty broad definition of symptoms to catch all the workers who are potentially positive.
Yeah, definitely. I thought that was really interesting. Only 53% ended up reporting fever. So of all health workers, exactly as you said, that's sort of concerning from the perspective of how do we screen people or screen healthcare workers, appropriately. And then again, as you said, there was a really small percentage of overall healthcare workers with COVID that actually had some sort of like identifiable travel risk factor, in terms of travel or having been exposed to a known patient early on in the pandemic. And I think that sort of, when I read that, to me, it sort of spoke to some of the discussion that's been going on about, potentially community transmission occurring earlier than we suspected. Granted, these are healthcare workers, so, that could be part of it. And as you said, there could have been some sort of level of nosocomial transmission going on, although, only 3% reported having been known being exposed to an inpatient with known COVID. So sort of hard to know. But still sort of interesting thinking about kind of the early days compared to kind of what's transpired since then.
Right. This is also what's interesting to me is, and I mentioned this before, how I think early on we started recognizing abdominal pain or abdominal symptoms were fairly predominant. Right. And they've got they've only really got 86 patients with symptoms. Or 86 people with symptoms, they're not even really patients. And about 15 to 20% had diarrhea or loose stools, and about 6% had abdominal pain. Mm-hmm. And I can't pretend that I've read all the papers, but this is the first time I can certainly recall looking at a paper and with a list of symptoms for COVID when they're doing that epidemiology, and abdominal pain is actually on the list with a number on it.
Yeah, right.
Yeah. So it's just like, all right, what do we got next?
So this is coronavirus disease 2019, infection among healthcare workers and implications for prevention measures in a tertiary hospital in Wuhan, China. So this was a study that was really trying to explore the clinical characteristics or describe the clinical characteristics of healthcare workers with COVID-19. It was a single center case series. They had over 9,000 healthcare workers that they looked at, which is quite a lot. And there was sort of a whole slew of different findings. So I'm just going to highlight the ones that I thought were sort of interesting. 71% of the healthcare workers that tested positive were women. The median age was actually 36 years, so fairly young. But a really interesting finding to me. So 15% of the healthcare workers that tested positive worked in sort of what they called fever clinics or wards. So who were classified as frontline workers, compared to 1% of healthcare workers being non-first-line workers that were infected. But when the investigators compared these two groups, non-frontline nurses younger than 45 were actually more likely to be infected compared with first-line physicians older than 45. So I thought that was sort of interesting because there's some implications there for infection prevention and just thinking about who's at risk. And one of the things one of the points made in the discussion is that some of these patients that these non-frontline healthcare workers were exposed to may have been in the early stages of illness, and so they didn't know that they were sick, and that's sort of how transmission occurred. But I thought that, I had not seen it kind of quantified like that before, so I thought that was really interesting. The other thing was 0.9% of healthcare workers with COVID-19 were asymptomatic. So, we know that there's some level of asymptomatic transmission going on, so that was sort of interesting as well. And the other point here was that most of the infections that they found in healthcare workers in this population actually occurred in the earlier stages of the epidemic, which again, I think speaks to sort of the evolving thoughts related to infection prevention and PPE and making sure that healthcare workers were being sort of protected later on, once more information came out about the nature of the epidemic.
Yeah, so going to welcome a few more viewers: Juan Vasconcelos, Raju Bandaras, and Ahmed El Tanahi. Welcome. We are talking about healthcare workers testing positive for COVID in Wuhan. Yeah, I think there's some really interesting things, and again, all the caveats about me trying to explain data post hoc, but I feel like looking at the figure, the light blue is the non-first line workers, and the dark blue is the frontline workers. And you can see basically just, the graph is dominated by the non-first line healthcare workers, which to me is probably, again, I'm an optimist, but probably more a sign of anything that infection prevention measures work when we apply them. And then on the front line, we started doing PPE really early on when we started doing things. And just like you said about the time course, that healthcare workers were more likely to be positive if they were exposed early on, where we weren't using masks with every patient, we weren't masking every patient, we weren't using full PPE in every case when it wasn't obvious. But now that we're, aware that everyone's at risk, we're pretty universal about it. And I think, I don't know, again, I'm just kind of trying to explain this stuff or rationalize this stuff, but whether it's the non-frontline workers who they're either getting community spread outside of the hospital and they just, got infected on the sidewalk or on the bus to work or whatever it was, or in the community of the hospital, is it from the break room, from the other nurses they're friends with, that sort of thing. Who knows? But that to me, I think resonates, and I think is part of the reason why it's hard. But when I'm at work, we're all supposed to and try to wear masks all the time. We're at the nursing station. I'm sitting at my computer by myself and things like that.
Right. But even that probably has changed, right? It's evolved. Thinking and our knowledge has evolved too. And so I kind of like how this sort of quantified it in a way.
Yep, absolutely. And I think again, going back to the figure, one of the things that's most interesting to me is how the curve of the health workers kind of goes up and peaks and comes down before the total Wuhan caseload goes up. And I think that makes sense. Like I certainly early on wish I was wearing a mask more at work outside of patient rooms than I was. Right. But who knows? Yeah. All right, you've got one more paper for us.
Yes. So this is Coronavirus Disease 2019 test results after clinical recovery and hospital discharge among patients in China. This is a research letter by Wu and colleagues. This is really interesting to me because I think there has been a lot of it's still sort of one of these unanswered questions that we have. And so this was a cross-sectional study that was actually trying to describe the course of COVID-19 patients after discharge. And so they looked at 2 patients that were previously discharged that were then readmitted having symptoms and also found to have a PCR positive, SARS-CoV-2 PCR positive after prior negativity after having been discharged. And then they obtained, following those 2 patients, they obtained nasal pharyngeal swabs and anal swab samples from 58 patients who had been hospitalized for COVID-19 in Ludi, China, to essentially evaluate whether or not there was viral persistence. And so of those 60 patients in total, 10 patients, so about 16%, had positive PCR results after some time following discharge. 5 of those patients were positive from the nasopharyngeal swab, 6 with a positive anal swab, 1 patient had both. And of the 10 that were positive, 2 patients had sort of an occasional cough. Everybody else didn't have any other symptoms with this positive test. One of the 2 of these patients that still had a cough actually had developed sputum rather as well 5 days after hospital discharge. And so this was extrapolated to mean that this patient was having essentially prolonged viral shedding from their onset of illness. And for that patient, it ended up actually being 56 days. So much longer than prior estimates. Kind of interesting as an aside, one of the patients that was within this 10 patients who tested positive after discharge had actually donated plasma as well. During that period after discharge. And so they were found to have, or he or she was found to have a positive PCR 3 weeks after discharge. They ended up testing all of the healthcare workers that were exposed to that patient or who had helped sort of collect the plasma and who had not been wearing PPE, and none of them ended up having positive PCRs or symptoms. So kind of overall, I thought this was, obviously this is a very small sample, but I thought this was sort of interesting, just kind of looking at, the course of patients for a long time after discharge, and potentially this being some evidence that there is persistent viral shedding for a while.
Yeah. I think the bad news is after we get clinically better, we might still shed. I will say and Carly Goldstein has joined us. Welcome. We're talking about recurrent positive PCR after hospital discharge with negative PCR. I think early on, it's still hard to say whether patients are reinfected or get sick again, which I think is the big question. I think, having some sort of immunity versus the ability to get reinfected is a big question going forward. I think early on, some of the data on things like I think it was like toilet swabs in patient hospital rooms and stuff like that were pretty concerning for a lot of things. But it's turned out, PCR is testing the actual RNA and not necessarily for the presence of virus. So it's possible that we're getting positive PCRs, but not necessarily positive viruses. So the viral shedding may be just the RNA and not effective virus. Which is frustrating, but
definitely. But that's a really, really important point and a good point. I'm glad you made it.
It's just tough, and it's all the things. The PCR is a wonderful test for RNA. It doesn't tell us if you have the disease or the ability to pass on the disease. Just says we don't know if the plasma antigen tests that are starting to spread out now are actually they're telling us people have antibodies. They're not telling us people are immune. And hopefully we'll learn lessons about that soon, but we have no idea at this point.
Yeah, many questions remain, I would say.
Yep, absolutely. Further research is needed, as usual. But this stuff is, I think, more needed than usual.
Yeah, definitely.
Certainly more relevant. Great. I think that's all we got for today. Thank you for watching, of course. You can read these papers and more at JAMAnetworkopen.com, where everything is open access and free to access without a paywall. You can watch listen to the author interview portion of this video on the podcasts, on the JAMA Network Open podcast, which you can get at iTunes, Stitcher, or wherever else you get your podcasts. Of course, join us next week, which I don't remember the day is, but Tuesday, 3 p.m., Tuesday, June 2nd. Oh, it's June already. Tuesday, June 2nd, 3 p.m. Central Time, and get all the new JAMA Network Open papers every weekday, 10 a.m. Central Time. And of course, stay safe. Thanks for joining.